Sorry, my team screen is up. Okay. All right. I guess it's just my report for today. So, like I said, a lot of this is a review as far as the cardiovascular monitoring goes. So go back. I included the previous EKG PowerPoints that you guys can look at. We're just going to run through a couple things here that should be pretty familiar. But just think about your lead placement. No matter what system or what lead we're using, it operates on a negative to positive principle. So keep in mind that as impulses are traveling towards the lead, it's going to get larger. Away from it, it's going to get smaller. Be mindful of your limb leads, that you do have 4, even though we commonly only use 3. You also have the 3 augmented limb leads that, even though they're not actual electrodes, that they do provide you with augmented views of the heart. So just keep that in mind as you're thinking about how those extra views pop up. Think about your placement for your different EKG electrodes as you're looking at a 12 lead and kind of how those apply, so you're familiar with those locations. Be mindful of the difference between limb leads and precordial leads as far as views, and think about, for different arrhythmias, kind of what may be a more beneficial lead to evaluate. A lot of times we use lead 2 for continuous monitoring. V1 or V2 may be beneficial, or even V5, depending on what's going on with your patient. But if possible, and you have the ability to do multi-lead monitoring, you probably want to try and keep an eye on all the different aspects of the heart. So your traditional leads look at the inferior side. You can use your precordial leads to keep an eye on the lateral and anterior surfaces. So 12 leads are pretty beneficial if we can utilize them. Not frequently done in the operating room, but you may see sometimes, like in the EP or the cardiac room, you may use continuous 12 leads. So just think about that if it's a possibility. The reality is, if somebody needs continuous 12 lead monitoring, they probably don't need to go to surgery. Remember the different portions of the heart and what it's covered. So 2, 3 in AVF, inferior wall, V1 and V2 septal, V3 and V4 anterior, V5 and V6 lateral, 1 and AVL are going to be your high lateral. Remember, as far as criteria for stuff, that we're looking for greater than 2 millimeters of change in contiguous leads. For your bundle branches, remember the turn signal rule to go back and think about your interpretation, starting at the J point in V1 and coming back into the complex. And just look and see whether it's an upright complex or a negative complex. So like in this case, it's an upright complex for a right bundle branch block. This case, going in back from the J point into the complex, it's negative, so you've got a left bundle branch block. Don't get fixated on this, not any more than you did before. Just be mindful of kind of the interpretation rules you can use for axis deviation as well as the hypertrophy. It's just a refresher. Like I said, this isn't something I'm really wanting you to get fixated on. Be mindful of your QRS changes for V1, especially if you have RVH. And when we start worrying about patients with concentric hypertrophy, just be mindful that you may have a little bit more depolarization towards V1. LVH, usually you're going to have large S waves in V1. Again, not something really to get focused on. The next couple slides are a little bit more important when you start thinking about like myocardial ischemia, injury, those sorts of things. So with ischemia, just be mindful of the inverted symmetric T waves. As we progress through injury, look for your ST elevation. And then ultimately, after you've had infarct, look for your Q waves. Remember when we talk about Q waves, that pathologic Q waves are generally going to be wide, and they're usually more than a third of the height of the QRS in two contiguous leads. Like I said, those are just refreshers for you. The next slides after this are really the meat of what we need to talk about. So pacemakers and AICDs and implantable cardiac devices are really kind of the cutting edge of electrophysiology right now. What we saw historically for a very long time were very basic devices. The new ones are far smarter than a lot of times the people putting them in there. But the problem is, as technology advances, it gets to be a little bit harder to deal with the complications of it and the devices themselves. So we're going to talk a little bit about why we put pacemakers in patients, why we put AICDs in patients, and kind of the complications we encounter. So the biggest reasons that we see patients getting artificial pacemakers are some sort of bradycardic treatment. It may be an underlying pathology, or it may be medication induced. So a lot of times in our elderly patients, we'll see that because of inappropriate or excessive beta blockers, they may become profoundly bradycardic. So they may wind up getting a permanent pacemaker inserted just because of beta blocker use. And it seems like it would be easier just to wait for the beta blockers to get out of their system. But because of the long duration of action for some of those medications, it may be more reasonable to put a pacemaker in. The other thing you encounter is that there's often a risk of them doing that again. And maybe somebody doesn't find them, they don't survive the insult, stuff like that. Other things you'll see, patients with sick sinus syndrome will have pacemakers put in. And then we also have temporary pacemakers. So you'll see, like when you get to your cardiac rotation, that a lot of times those patients will have epicardial or cardiac wires placed for the first couple of days after having CABG or especially valve surgeries. And they can be used not only for bradycardia, but also for tachycardic rhythms. A couple different kind of pacemakers we do encounter. What I was describing is kind of cardiac wires. You may see that there's also transcutaneous, and this is kind of what you think about from back in ACLS, where you had pads that were placed on the outside of the chest. And then you may have temporary transvenous pacemakers that are utilized. It's very similar to a PA catheter, but it's got a pacing electrode in it. So you kind of have to evaluate what's going on with the patient and how this process flows. So if you have somebody that comes in bradycardic and maybe they get atropine, maybe they don't, maybe it's a high degree of block and it's not amenable to being treated with medications, they may quickly go to using a pacemaker. So in the emergency room or the ICU, a lot of times what they're going to do is start off with a transcutaneous pacemaker. So just putting those leads on. And the same thing we would do in the operating room. We would just start off by putting pads on the patient. And what you're going to do at that point is basically use the minimum amount of electricity to achieve what you need. So you'll set the patient's heart rate, usually somewhere between 60 and 80, and then you're going to slowly increase the voltage until you get what we call electrical capture. So electrical capture basically means that you're seeing that big paced QRS complex that we think of as coming from a pacemaker. And then after that, you want to make sure that the heart is actually responding as well as the electrical system. So you're looking for mechanical capture now to verify that the heart is pulsing at the same interval as the electrical impulses you're seeing. So if you get the patient stabilized with transcutaneous pacemaker, then you've got to think about what comes next. So is this a situation you can resolve quickly? Is this perhaps like an overdose or some sort of event? Maybe hypoxia should resolve with oxygen. But is this something quickly to resolve, or is this more of a long-term condition? So at that point, then you've got to decide what to do next. So this may be somebody that you put a transvenous pacer in. Like I said, it's essentially the same as a PA catheter. And indeed, some of the PA catheters do have set up for transvenous pacers on it. Or is this somebody that maybe we're just going to do transcutaneous pacing and then take them to the EP lab and put in a permanent device? So whatever setup you're using, you're going to have a combination of leads, whether they're leads as basic as like a sticker on the chest or implantable leads, and then some sort of pulse generator that actually provides the electricity through those leads. So it may be a Zoll that's providing your pulse generator, or it may be an external device, or it may be the implantable device as well. We're going to talk a little bit about the definitions of those things. So the generator is exactly what it sounds like. It's an energy source that provides the current to go through the leads. The leads are an insulated wire, which is very important because a lot of times the wire itself will be in contact with other things until it gets to where it needs to be. So there'll be a couple of sections on there that are exposed metal that are actually in contact with either the endocardium or the epicardium. And that's where the energy is actually going to be exposed to the heart itself. So the lead goes down to the electrode from the generator, and then the electrodes would actually contact the heart. Now, there's a couple different types of electrodes you see. You have unipolar electrodes. So in that case, you're going to have kind of one electrode that basically it provides kind of a grounding, or you can have bipolar, which is where you have two electrodes. And the nice thing about bipolar is because you're basically going from point A to point B, you can use a lot less energy as opposed to unipolar where the patient's kind of the ground, so it takes more energy. You may also see that you use multiple electrodes. So for instance, sometimes we'll see leads that will go across the septum. So you may have like biatrial electrodes, or you may have biventricular electrodes. So in that case, the electrode is actually transversing the septum. So just be familiar with the devices. Like I said, it used to be a lot more simple. We just had basically ventricular pacemakers or atrial pacemakers. Now there's a lot more components to it. You need to memorize this table. This is basically how we know what a pacemaker is going to do. So when you look at a pacer, you're going to see these Roman numerals 1, 2, 3, 4, 5. And then it describes the activity for each of those areas. So 1 is the chamber that's paced. So you may have an atrial pacemaker, you may have a ventricular pacemaker, or you may have dual AV pacemakers, or you may have no pacers. Maybe it's not a pacing device at all. Or maybe it's not programmed at this point to do anything. Maybe it's not active. You may have a sense pacer. So what I mean by that is that instead of it being a non-demand device, that it's actually on demand. So it pays attention to see what the patient's heart rate is, and then it determines its response. So you may have people, especially with like ventricular pacemakers, where it's just set for a default rate. Usually it's round number like 60, 70, or 80. So if you're looking at somebody and you see that they've got a big wide QRS and it's kind of that clock regular rate of like 60, 70, or 80, be very suspicious that they may have a pacemaker, even if you don't see pacer spikes. A lot of times you can ask the patient, or you may have to do a physical exam to look around and see if you're able to locate the generator itself. So in those cases, you may have an atrial sensing, you may have a ventricular sensing, or it may do both. So just be mindful of what kind of device you have, what it's going to do. For number 3, you have the response to sensing. So what that means is that everything can be programmed differently depending on the device. So sometimes there's nothing done differently when it senses. If you have an inhibit, basically what happens is if the pacemaker senses that there's like a traditional or a spontaneous depolarization, it will not activate. So this may be that it recognizes the heart rate is appropriate. It's not outside of those parameters, so the pacemaker doesn't do anything. On the other hand, you may have a patient that falls outside of the set parameters. Maybe they become bradycardic, so then the device will trigger. You may have dual, which means it's capable of doing both. The dual is the most common that you're going to see as far as like response to sensing. Rate modulation may mean that it is able to adapt a little bit. That's not very common. Usually if you see that, it's more in response to like overdrive pacing. And then the last one is if you have multiple locations where it's able to pace. So is it like biatrial, biventricular, or is it both atria and ventricular? So make sure you know that chart. You'll see that again on boards for sure. This is just kind of what I was talking about as far as the activity. So inhibition, it's not going to pace. Triggered, it will discharge. And they really just use that for testing of devices for the most part. So it may be to demonstrate that it's able to pace. Sometimes what you'll see is they use medications to alter the heart rate. So they may make the patient bradycardic to test the device. You may also see that they will increase the patient's heart rate just to prove that they can do it and they have good capture. You may also see from a modulation standpoint that there's kind of factors that may affect things. So think about the modulation as kind of like the artifact setting, if you will. So they may be able to, use that to determine the patient's heart rate actually hasn't increased. It's just artifact. If you think about like an EKG tracing where you get all that artifact in there and you're like, well, I don't think that's really what the heart rate is. I think it's just artifact. And then you can kind of go through and separate out the real QRS complexes from the artifact. You may see that there's some modulation settings in there where they're able to kind of tailor that for the patient. And then we talked about the multiple site pacing. The biggest thing we're seeing with as far as like multi-site pacing is going to be ventricular pacers for people with like horrible cardiomyopathies. You will occasionally see it for AFib, but BIV is the most common one that we do see. This is just an example of some of the different pacemaker waveforms. So up top, you have a traditional QRS complex where you have the atria working and then the QRS the ventricular working. Down below, you have a atrial impulse. So the atria is still working normally on its own, but the ventricles aren't working. So you see that pacer spike and then the big QRS complex that follows it. So the atria is following its traditional pathway. The ventricles are responding to the electrical stimuli. So the second one's a ventricular pacemaker. The third one is an atrioventricular pacemaker. So if you look, you'll see there's an atrial impulse and then, or an atrial spike, and then the atrial impulse is the atria depolarized. And then you have a ventricular spike and then a ventricular depolarization. So the last one's going to be an AV sequential pacemaker. Part of that just kind of guides or lets you know how sick your patient is. Sometimes you'll see the patients just have ventricular pacemakers and there's no atrial activity at all. So you got to keep in mind that they've lost a pretty significant amount of their cardiac output by not having that ventricular component. They're also at a little bit of an increased risk for embolia because the atria is not contracting effectively. So what do we have to do as far as pacemakers in the perioperative setting? A couple different things that you have to think about. One is how you can safely manage this patient. Two, what do I need to change or do I need to change anything? A lot of what you'll see is it depends on the facility itself. So some places you'll have like an EP service. They may need to come evaluate the patient or interrogate the patient's AICD or pacemaker beforehand. They may not. Historically, we had them come evaluate it before the procedure and after the procedure just to make sure it hadn't been artificially influenced by the electric cautery or anything else that happened. We're starting to see less and less of that, or like remote check-ins, as opposed to having somebody actually come look at the patient. They may just do a phone check-in. They may be able to Bluetooth to the device, things like that that kind of allow them to figure out what's going on without physically being there. From our standpoint, things we need to think about, first of all, there's usually a pacer setting on the cardiac monitor. So you may need to turn that on or off to allow you to see the paced impulses. Just be familiar with whatever the kind of functionality of your monitor is. Some do it automatically, some you have to do it manually. But like I said, if you look at the monitor and you have what seems like it might be paced, so like a clock regular rhythm of like 60, 70, or 80 in a wide QRS complex, just be cautious and make sure that you know if the patient does have a pacer or not. And part of the reason for that is that we want to be careful what sort of electricity we use around that pacer. So if you do have somebody that's got a pacer in place, you want to try and avoid putting the grounding pad anywhere near it. You also want to try and avoid using monopolar electric cautery anywhere near the device if possible. There's some apps out there. One of the really good ones that a lot of people use is called Safe Magnet. There's another one out there that I was looking for just a second ago. that will kind of help you out. But I think Magnet Master and Safe Magnet are really the most common ones you're going to encounter. And basically, they provide you with different recommendations depending on the device. They take the manufacturer's recommendations and then talk about like the location of the procedure and what you should or shouldn't do. As a general rule, if it's on the other side of the body from the pacemaker, it's probably okay. So generally, devices will be placed either under the right or left clavicle or sometimes in the abdomen. So we kind of use the waistline as a divider. So if they're having lower extremity surgery and you can put the grounding pad on the lower body, you're usually okay without having to do anything with the device. Other things you kind of want to keep in mind, historically, putting a magnet on a device would put it into a non-demand mode. So it would just go to a regular rate of 60, 70, or 80, depending on what the backup programming was for it. Some of the newer devices don't do that. So just be very cautious as far as what you do. And we'll talk about magnets again in just a minute. So BiVi pacers put electrodes in multiple different places. So you'll have one lead that goes into the right atrium, and then you'll have a lead that goes into each ventricle. Like I said, it goes through the septum. And the goal there is that you're able to increase the patient's synchronization, so the right and left ventricle are working well. Historically, these people have bad cardiomyopathy, and as a result of that, the impulses are delayed as they transmit. So if you're able to use the pacemaker to kind of resynchronize the ventricles, it improves your cardiac output. So something for you to think about with these patients: one, if they have a BiVi device, they're probably pretty sick. Two, they're pretty dependent on it. So this may not be somebody that can go without having their pacemaker on. So like I said, usually we will put this into a non-demand mode if we do anything with it, which is probably fine for them because they're going to default to something that's adequate. But be very cautious about turning these devices off or manipulating them. The other thing that we get involved with is the actual placement of these devices. So a couple different ways you can do the anesthetic for putting in a pacemaker. You can put the patient under general anesthesia. It's always a default. But a lot of times, just because they're so sick, what we'll do is just do kind of sedation and a local. Sometimes we'll do like a periclavicular block. Sometimes we'll do like a cervical plexus block. It really just depends on where they're putting the device in. The surgeon may just infiltrate with local. And basically what they do, like I said, is they're going to make a little incision below the clavicle, and then they kind of create a little pouch in there. And the pouch is where that generator is going to live. And then they just put the electrodes into the subclavian and run them down into the heart. It sounds simple, and sometimes it's pretty straightforward, sometimes it's not. But a lot of times with those very sick patients, it may be beneficial to not do a general anesthetic because they may not tolerate it very well. So just something for you to think about there. So these are the general requirements we see as far as who gets BiVi. And I think that if you go back and look now, that this may be a little bit generous, that a lot of times now the EF is even lower, like 10 to 20%, not 30 to 35. I think that 30 to 35 you'll see is in kind of younger people with bad disease early on. But so bad EFs, people that need that resynchronization, for some reason they've got an intraventricular conduction delay like a bundle branch block, they may benefit with that resynchronization therapy. Or patients that have a history of kind of cardiomyopathy-induced cardiac arrest. So think about a lot of times the young athletes that we see that are having out-of-hospital cardiac arrest, they may benefit from having a pacemaker placed. So like I said, for a long time, kind of our go-to was to put a magnet on these devices. And what that would do is put it into an asynchronous mode with no sort of rate modulation. So it would just go to whatever the default rate was. As the devices have evolved, we've noticed that you can't just use that shotgun approach to everything. So you may put that magnet on there and nothing happens. If you've never seen one of these magnets, it almost looks like a small donut, and you just set it over top of the patient's pacemaker or ASCD. Sometimes it will be close to the surgical field, so you may have to put like a big tegaderm or something like that over top of it to hold it in place, and then they can prep over top of it. Sometimes it's far away from the surgical field, so know what's going on there, know how you're going to intervene. Really, the hardest part of that is finding the magnet a lot of the times. If you put a magnet on there, it's probably a good idea to have somebody come evaluate the device afterwards. It's also a good idea if you don't know what's going to happen that you get the EP service or the cardiologist that put the device in to kind of give you recommendations beforehand. Because they know the device and they may just tell you to talk to the company representative, or they may provide some just clear guidance for you. This is what you need to do with our device. So just make sure somebody's paying attention to it. We talked about this earlier. The other thing you want to think about that I didn't touch on is backups for the pacing device. So if you have somebody that has a pacer in place, there's always the possibility that the reason they're there is it's not working appropriately. So maybe they're coming in to have their humerus fixed, but they're getting their humerus fixed because their pacemaker wasn't working and they syncopized and broke their arm. So it may be helpful to have like a transcutaneous pacemaker close at hand. Other things to think about for these patients, if you're not sure the device is working correctly, you may consider going ahead and putting pads on them. So that way you can use kind of a transcutaneous pacing if need be. AICD, implantable cardioverter defibrillators, are very similar to pacemakers. And a lot of times you will see that patients will get combination devices. So they'll have an AICD and a pacemaker, but you can't assume they're one or the other. Talk to the patients. Most of these folks will carry a little card with them that tells you what the device is and kind of how it's programmed. If not, it may be scanned into your EMR, or that cardiologist may be able to provide it for you. But AICDs are designed to terminate either VFib or VTach. And the way they work is just measuring the R to R interval. So what they'll do is look and realize that that R to R interval is very short. And as a result of that, the patient's in some sort of tachycardic rhythm. As I said, they're designed for VFib or VTach, but you'll see sometimes the patients will go into like an SVT or something, and it may have a wide enough complex to meet the pre-programmed specifications for the device, and they'll wind up defibrillating SVT. Obviously not what we want. It probably doesn't help their heart rate most of the time either, but just be mindful of that. The other thing you'll see with these devices is they may malfunction for whatever reason. Sometimes it's because wires get cracked. Sometimes as the batteries get a little bit later on in life, they're not as sensitive as they've been. Sometimes the patient will move the wrong way or get their heart rate up enough that it's in whatever the parameter is, and they'll wind up getting defibrillated multiple times. I've seen patients that were having inappropriate device firing, and it may have been going off like 10 or 20 times before they got to the hospital. So just think about that. Other things you'll see as far as criteria, usually it looks at the kind of width of the QRS complex because it is primarily targeting ventricular rhythm, so it's going to be a wide QRS. You may run into trouble if you've got kind of an irregular heart rate because it's looking for that R to R interval. So if you've got an irregular R to R interval, it may not be able to calculate the heart rate appropriately. Or maybe you have a whole lot of beats that are close together and you have a period of tachycardia, but it's not sustained. So just be cautious with these devices sometimes. The other thing is they may fail or they may not work quite the way you want them to. So if you have a patient that's in VFib or VTach, even if they have an AICD in place, go ahead and defibrillate them if it doesn't work. And it's very unnerving while you sit there and wait on the device to work. But just be cautious at the same time that you've either turned the device off or you know what's going to happen. But sometimes what you'll see is that the reason they're in VFib or VTach is because the device isn't working. So just be mindful of that. What questions do you guys have? And then we'll hop over into the vascular monitoring. Leaky, did I answer your question about non-demand and demand pacing? Or did Ruber? Yeah. Megan brought up a good point. I mean, we're kind of kidding, kind of not. The people that have been inappropriately defibrillated will have like some PTSD. Like there's legit scare that device is going to go off. So they do everything they can to avoid it. But just be mindful that they may be kind of a little bit upset when you wind up getting involved with them. All right, we're going to carry on to the vascular monitoring stuff. So the most common vascular monitoring devices that we used for a long time were central venous pressure lines. So we would put a central line in. For us, usually it's going to be the right IJ. And then the catheter is going to sit right at the junction of the vena cava and the right atrium. A lot of times we would use this as kind of an indicator of volume status or kind of pressure inside the heart. But the problem is there's so many things that can affect it. It may not be as accurate as we want it to be. So we're going to talk a little bit about central venous pressure. The big thing I think you need to take away for CVP is that a snapshot with a CVP is not very helpful. It's more of a trending device. So, if I start seeing my CVP increasing, things that could cause it, fluid overload, pericardial effusions. If I see my CVP dropping over a long period of time, I may be volume depleted. But they're not very good as like one little snapshot. Normal CVP for somebody that's awake, spontaneously breathing is 1 to 7. And the reason I put that in there is that there are things we do that will affect CVP. So if you have somebody that's being ventilated by positive pressure ventilation, you may have an artificial increase in the CVP because the intrathoracic pressure is increasing. Whereas if they're breathing spontaneously, since they have that vacuum of the diaphragm dropping down, it doesn't tend to alter it quite the same way. These are just some indications for central venous pressure lines. Obviously, CVP monitoring. We may use this either in conjunction with a PA catheter, or you may use it separately. So all our PA catheters have the ability to monitor CVP. You may use kind of a combination device like I was talking about earlier with a temporary cardiac pacing wire on it. We may use temporary hemodialysis lines. A lot of times will be very close to where you can use them for CVP monitoring, not all the time. Sometimes we'll put central lines in for caustic medication. Sometimes we do it to give blood and fluid very quickly or large volumes. We may use it as part of a targeted therapy. So you may actually put a central venous catheter in to aspirate air emboli. You may use it to aspirate clots, or you may use it for like kind of directed thrombolytic therapy. We also put central lines into patients to do repeated blood testing, although not quite as often as we used to, and then also for poor vascular access. Again, we're not commonly doing IJs and that sort of thing anymore for vascular access patients. A lot of times now they're getting like midline catheters or PICCs. So we're going to talk about some of these waveforms, and you'll probably see these again, so I would make sure I paid attention to them. The atrial wave, and I just remember it, is the A wave is the atrial wave. Occurs after the P wave. So what happens is you have the atrial depolarization, and then you have increased atrial pressure. And this is really the atria that's starting to fill from that preload. So the atria starts to dilate, and then you have that A wave that appears. The C wave is kind of like the ending of the atrial involvement. So you have kind of this drop in the atrial pressure, and then you see that the ventricle starts to contract. And when that ventricle contracts, you're going to see that the tricuspid valve kind of elevates up into the right atrium. And that's really where you're seeing that change in pressure. Because remember, your CVP catheter is sitting right there above the right atrium. So you're kind of seeing an indirect evaluation of what's going on in the ventricle there. So you'll have your R wave, and then if you look at your pressures, a lot of times you'll have your C wave there. A lot of these things are very academic and they're not realistic. So you may not be able to see all these different waveforms on a CVP tracing. But for your test, you're probably going to need to know where they occur. And even if you can't specifically tell which waveform it is, if you think about what's going on inside the heart, a lot of times it'll kind of guide you along. The X wave is the drop in atrial pressure from the A wave down through the ventricular systole. So think about this as like systolic collapse. So what you're seeing here is that the right ventricle is starting to collapse, and you're getting a little bit of a decrease in the pressure there. And then ultimately what happens after that is that you start to have the blood filling the right atrium again, so pressure goes back up. And then you may or may not see the V wave of your tricuspid valve as it starts to open. So just think about kind of how those flow through things. And then your Y descent is the tricuspid valve opening, where you start to get your blood dropping down into the ventricle. You may call this diastolic collapse. You may call it your Y wave. These are the ones that are really hard to see sometimes. Usually your A wave is pretty clear. Your X wave is pretty clear, but the V and the Y are hard to see sometimes. So some things to think about that can cause like weird CVP waveforms. If you have somebody that's got AFib because you don't have kind of that consistent atrial filling, you may not have an A wave. Likewise, you may have a kind of a larger C wave because there's more volume in there when it finally contracts. If you have somebody with tricuspid regurg, you may not see an X descent because the valve is incompetent, so you don't have consistent filling there. If you have somebody with tricuspid stenosis, you may have a really large A wave because of that back pressure and the inability of it to kind of effectively contract. You may also not see the Y descent happen there just because it's masked by other waveforms, usually that big A wave. Any questions on the CVP catheters? So we're going to move on to PA catheters. If you've never seen a pulmonary artery catheter before, this is kind of the standard setup for it. We're going to talk a little bit about the different lumens and kind of how different parts of it work and kind of the principles behind it, those sorts of things. But this is a pretty traditional setup for it. So if you look there in kind of the center of the screen, there's a little balloon. And what you use that balloon for is to actually float this down through the pulmonary arteries to where you're able to wedge it in place. And then with that balloon inflated, it basically isolates everything behind it. So it allows you to look through the lungs to see what the left side of the heart's doing. Over time, we figured out that TE may be a little bit more effective means of monitoring the heart. So we don't use PA catheters quite as often as we did. But I think you'll still see that they're pretty common for open cardiac procedures. Not every case, but for the most part, they're pretty common. When you look at the lumens there's a couple different things you're going to see. So most of these will have medication infusion ports, but they also have monitoring ports on them as well. So usually what happens is you've got a very distal port that's coming out beyond that balloon, and that's what you're going to use to monitor your pulmonary artery pressure, your wedge pressure. Coming back from there at about the 30 centimeter mark, so if you look there, you'll see that there's 3 lines kind of right underneath the balloon. That's your 30 centimeter mark. You'll have another monitoring port right there for CVP. If you come back further, you'll have a 40, 50, 60 centimeter mark. So there's lots of different kind of measuring points as you look at the balloons, or excuse me, at the lines. And those are really important when you start thinking about how deep your catheter is. And we'll look at some important numbers there in just a second. Be mindful that you have a clamp on the balloon itself. So if you look down at the bottom there where the syringe is, there are special syringes for these. Most of these are going to be a 0.5 to 1.5 cc's of air that go into that balloon. There are some other ones out there, but these have special syringes that'll have like a stopper in there so you're not putting too much air in. Some places are insistent that that syringe stays attached. Other places, to avoid inadvertent inflation, will have them detached. There's also a slide lock down there. So if you look at the white thing in front of the syringe, that's a slide lock that helps avoid accidental inflation. You may also use that to lock the air in there. Say, for instance, you're monitoring pressures. You don't want to have to stand there and hold the syringe. So you may inject the air and then lock it in place. This is just kind of an overview of the different lumens that we were talking about. We'll talk a little bit more about how these work in just a second as we kind of look at the waveforms as it moves through the heart. So back in the day, Swan-Ganz, which were 2 different people, and their colleagues came up with the pulmonary artery catheter as a tool for monitoring patients with acute MIs. They would insert them through the right IJ, and then they would advance them down through the heart. So you would put it in through the right atrium. You could use that right atrial pressure, usually about 20 to 25 kind of as a CVP as you're transitioning down through there. So if you look, that first waveform is basically a CVP waveform. The second one you'll see is after the catheter gets down into the right ventricle. So it looks just like a ventricular waveform that you would see on an arterial line. The third one looks like an arterial waveform because it is. It's just a pulmonary arterial waveform. And then the last one you're going to see is actually after the balloon is inflated and the catheter is wedged in place in one of those distal pulmonary arteries. So that way you've kind of blocked off everything behind you and you're looking through to the left side of the heart. Is there anybody that's never seen a pulmonary artery catheter used or put one in? All right, good. Like I said, we're using them less and less, so they're kind of hard to come by sometimes if you're not like in a CVICU. So these are good reference points for you as far as where your PA catheter is from a depth perspective. So just think about those landmarks we just talked about, and basically each one you're going to advance by 10. So right atria at 20, right ventricle at 30, PA at 40, and then the wedge is a little bit shorter as far as like the onset, but generally it's going to be about another 10 centimeters. So 20, 30, 40, 50 for your different depths. Most of the catheters are marked at 10 centimeter intervals, but not always. You may also see there's some variation as far as the size of the catheters for length. So some of them are longer than 110 centimeters, some are shorter. Especially if you have one that's more of like a pacing catheter or something like that, it may be a little bit shorter because you're not necessarily trying to get it down into the pulmonary artery. Just be mindful and aware of what you have. So there's a reason we don't use pulmonary artery catheters on everyone anymore. There are some complications associated with them. Some things we know are going to happen. So if I take something like a guide wire or a pulmonary artery catheter and stick it in the ventricle, or even the atria for that matter, I know that those cells are going to be upset. So when I advance it through the atria, it's pretty common to see PACs. Likewise, when I get down into the ventricles, it's pretty common to see either PVCs or little runs of ETAC because I'm irritating those cells as I start poking at them. Things you want to be cautious. You may see that patients have kind of transient bundle branches or a complete heart block, depending on what's going on. So one of the things we try and avoid is if you have somebody that has a known right bundle branch block or a high degree block, we may not put a PA catheter in there because they may not tolerate the hemodynamic changes associated with the cell pathology as it moves down through there. It is possible to tie these catheters in a knot. Probably a bad thing to have inside your chest because you can't get it out very easily. What you'll see a lot of times is patients that are having open cardiac procedures, just because the way the patient's moved around, the way the heart's moved around, you may get a knot that's tied in that catheter during the course of the surgery. So before we close those chests, we'll go ahead and make sure that we have free movement of the catheter. So just be cautious with that. If your catheter were to become inadvertently inflated and not detected, you do run the risk of having a pulmonary infarct. Because if you think about it, that balloon being inflated means there's no blood getting past it. So any tissue distal to that is no longer perfusing. So that's one of the reasons so many places are very cautious about, how they maintain the syringe on there, what they do with the lock, those sorts of things. So your catheter doesn't inadvertently wedge. If that catheter does wedge or you do wind up with pulmonary infarction for any other reason, it's somewhat common to have rupture of the pulmonary artery. That tissue is under a lot of pressure, so if it becomes ischemic, it's probably not going to do real well. It's not going to perfuse as well. So just be mindful of that happening. And then other things for you to think about, how would you recognize that? So things you may see, they may begin to cough up blood. If you have a widespread or kind of a large injury, they may become profoundly hypotensive. Very hard to treat, very hard to get the patient stabilized because there's not much you can do other than getting into the chest quickly. The good news is most of the time these patients have already had cardiac surgery, so it may be as simple as just opening their sternal wires if they're fresh. So that's a possibility. These are the people that will wind up having surgery at the bedside. And we'll talk a little bit about some other things you can do in just a second to treat PA rupture. Other things you'll see if the catheter remains in place, there is an increased risk of endocarditis or valve injury. So oftentimes we'll get these out within the first 12 to 24 hours post-surgery. So if you do have a patient that you think has ruptured their PA, there's a couple different things you can do. First of all, make sure they're adequately oxygenated. So most of these patients will still be intubated. One thing you may have to think about is depending on how they access the chest. If they're going to go back through the mid-sternal incision, it doesn't matter as much. But if this is like a minimally invasive procedure, you may have to transition to a double lumen tube. You may be able to increase the PEEP and help kind of tamponade the chest to help reduce the flow of the blood. Very temporary, and it's kind of a double-edged sword because while you're stopping the bleeding, you're also going to stop the adequate perfusion in the heart. So just something for you to think about there. There's not a whole lot of choices. If you have somebody that's anticoagulated and you're not on bypass, you may be able to give more protamine and reverse any sort of circulating anticoagulation at that point. If they're on bypass, please don't do that. You'll kill them deader than possible. They may do an interventional procedure going in with a bronchoscope to try and temporize the bleeding. Sometimes they can put stents into place. Sometimes they can inject epinephrine. A lot of times, though, if you've got a PA rupture, they're going to wind up having to have their chest open. And then what do you do with the catheter? So if I've got somebody that had a catheter in place and now they've had a PA rupture, do I try and float the balloon to inflate proximal to the hemorrhage because maybe I can occlude the blood flow there, or do I take the catheter out? So just a couple different things for you to think about. Like I said, ultimately they're going to wind up having to have surgical therapy to correct this. Usually they're just going to sew a patch over the bleeding pulmonary artery. But sometimes, depending on where it is, they may wind up having to resect that part of the pulmonary artery. Kind of a devastating injury, and it's very hard to manage, especially if you're not in a cardiac center. So for Dr. Schmidt, we'll put the West zones up there. Generally, we use the PA catheter tip in zone 3 to monitor our wedge pressure. And as I said, it's basically looking all the way through the lungs to the left side of the heart. Alternatively, if you're not able to get the catheter to wedge, you can oftentimes use your PA diastolic pressure as kind of an estimate of your wedge pressure. Or maybe you want a little bit more consistent monitoring, so you can use PA diastolic for that. So numbers we get from the PA catheter, your left ventricular end diastolic pressure provides information, but there's some situations that can really kind of provide a conflicting picture. It doesn't provide a good estimate of compliance. If you have somebody with aortic regurg, it's going to artificially increase your numbers. PEEP may affect things because you're increasing the thoracic pressure, thus increasing the pressure on the heart. If you've got a VSD in place, you may have altered flow, so it may not provide you with a good estimate. Or if you have somebody with any sort of mitral problem, you may not get good numbers. So it's important for you to know what the patient's valvular status is with this in place. That's one of the reasons that a lot of times we've gone to using a TE versus using the PA catheter, because it allows us to actually see what the valves are doing. So we're just going to look at some weird PA catheter waveforms. So mitral regurg, you may have a tall V wave. You may notice that the C and the V are fused together. You may not have an X descent. Kind of unrelated to the severity of the mitral regurg, you may notice that there's a change in the left atrial compliance and the left atrial volume. If you have stenosis in the mitral valve, you may notice that there's kind of an early Y descent that may kind of, I would say, smudge together. A lot of times patients with mitral valve issues will have atrial arrhythmias. So you may notice that they're in AFib, and as a result of that, you may not have an A wave at all. So just be mindful of that in those patients. Likewise, when you start looking at cardiac surgeries, you'll see that it's fairly common to have to cardiovert patients that are having mitral valves either repaired or replaced. So just keep that in mind. Usually those patients, they're going to have their chest open already, and you're probably not going to be the one defibrillating them. Usually the surgeon will take care of it. Kind of the cool thing, since they are in the chest, usually they can just look at the heart and tell what the rhythm is without even looking at the EKG. because they are observing how the heart's contracting. So if you've got somebody that's an AFib or VFib, it's pretty easy to see from the outside. If you've got somebody that's had a big left ventricular MI, you may see that they've got like big A waves because the left ventricle is very non-compliant. So think about like a kid with kind of a fixed ventricular volume. You may also see that as the systolic dysfunction increases, that you have an increase in the end diastolic volume as well as the end diastolic pressure. And then ultimately the PA wedge pressure is going to go up. Which, when you think back to why we started using Swan-Ganz catheters, that was a big part of it. This has kind of fallen out of favor, but for a long time we were using mixed venous oximetry as kind of an evaluations of patients' cardiac output and shock. It's not quite as popular as it was as we've turned to like TEEs and other less invasive monitors like lactate and stuff like that. But you may see that mixed venous oximetry is still used. It's just not very common anymore. So this is just kind of an example of when you could use that mixed venous oximetry. So if you've got kind of stuff stable, so your hemoglobin's not changing, your arterial saturation is not changing, and your oxygen consumption stays the same, the mixed venous oximetry is kind of an indirect indicator of cardiac output. The problem we run into, and the reason we don't use it as often, is because many times all those factors are changing at the same time. So it may not give you the best estimate of stuff. But if you do have all those things stable, what you'll see is like if your cardiac output starts to fall, that mixed venous oxygen saturation is going to start to decrease as well. So if you've got somebody that's got a low venous saturation, it may mean they need to be transfused or they're hypoperfused for some reason. Like I said, it's kind of problematic because oftentimes we've got multiple factors that are changed in there. It's not just one thing. Remember the formula for cardiac output. Remember these numbers for cardiac output. You'll see these again and again and again, and not necessarily on this test, but on boards you may have to calculate things like SVR based off of some of the components they give to you. So know what your normal volumes are, know what your normal flows are, and then how to calculate them. And like I said, you may see that again on your boards. So how do we use the PA catheters? Historically, what we've done is what's called bolus thermodilution. So you've got a couple different waveforms or a couple of different monitoring points on this catheter. And what you do is inject a known temperature fluid, and then based off of the temperature change from point A to point B, it's able to calculate the cardiac output. So we inject it through the right atrial lumen, and then down at the PA catheter tip, it's going to again evaluate the temperature change. Usually we're going to use this series of 3 attempts. One thing we do run into problems with is because these patients are generally fluid overloaded, if you're checking PA pressures as frequently as like every 30 minutes or an hour, that's another 30 or 40 mLs of fluid you're giving that person. So sometimes what we'll do is if they are fluid overloaded, we'll just check it once if it's consistent with previous values. So this is an example of what you would see as far as the area underneath the thermodilution curve. So top one there, you get kind of a normal cardiac output. If you have somebody with a low cardiac output, it takes them longer to get back to that normal temperature. On the other hand, if you have somebody with a very high cardiac output, they're going to get back to that temperature very quickly. So problems with thermodilution, and part of the reason that we don't use it quite as often as we had before, in addition to what I was talking about with the fluid, there's issues that you run into that may cause kind of artificial values. So if you've got any sort of intracardiac shunting, it can be problematic because you're not getting consistent flow. If you have any sort of regurg, because it's going to alter the flow through the heart, the temperature may be altered. I have mishandling the injectate, but if you don't inject consistently, you may not have an effective temperature monitoring. So part of that is like person dependent. So I inject it one way, Haley injects it another. So that can lead to problems for you as well. And a lot of times, if you go back and look at cardiac output values in somebody that's got a PA cath from one shift to another, you will notice that there's kind of variations there. Other things, fluctuations in the patient's temperature can be difficult to accommodate. and may cause some inaccuracies. They were originally used for patients that were kind of a normal temperature, so 36.5 to 37. If you have somebody post bypass that's still cold, or coming off a bypass, or they may still be cold, you may have some inaccuracies in your temperature. And then what if you're giving medications, especially through that PA catheter or another catheter close to that, and they're cold fluid or cold medications? Those things may affect the temperature measurements as well. So kind of the solution that was come up with that after that was continuous cardiac output devices. So this still uses a thermistor, but instead of having fluid, it just releases heat. So it's going to heat that blood with a little kind of wire in the right ventricle, and then it measures the temperature change. And so you're not having fluid instilled, you're just having a temperature change from the catheter. And usually the way this works is because it is continuous, it updates about every 30 to 60 seconds, and then it maintains kind of a running average for you over 3 to 6 minutes. And what they found as far as comparing it to thermodilution is it's more accurate, it's more precise, so beneficial, but not quite as predominant as we would like to. One thing you do tend to see, even with the continuous cardiac output devices, that you have delays in patients that are unstable, which really the biggest reason we're using this is because patients are unstable. So it may not be the greatest picture ever. Just something to think about there. And the other thing you see is compared to thermodilution is it tends to be a little bit more accurate when patients are being positive pressure ventilated. Another device you may see is the Pulse Contour, and there's a couple other non-invasive monitors out there. I just picked one. And basically what they do is use an arterial line tracing to estimate the cardiac output, the pulse pressure variation, and the stroke volume variation. Information you can take away from these, and really what they were kind of targeted at was fluid responsiveness versus medication responsiveness. So is this somebody I can treat with volume, or is this somebody that needs to have a vasoactive infusion? The downside, it really depends on an algorithm, and you can get into issues with the catheter placement. If you have somebody that's in AFib, you don't get accurate measurements. If you have somebody that's got a kind of a tortuous artery, like all the vascular patients we see, it may be problematic for you. So if you've got vascular abnormalities in that artery, you may not get a great waveform. If you've got somebody that's on vasoactive medications, it may alter things. So if you've got somebody that's on an arterial vasoconstrictor or vasodilator, it can affect the quality of the arterial tracing. So you may not get a great waveform, which may affect your values. In a perfect world, you would be able to do an initial correlation with a known cardiac output and then use it. But most of the time, the reason we're using these devices is so we don't have to put in any sort of continuous cardiac monitoring device. So just something for you to think about there. What's kind of become the gold standard now is either transthoracic or transesophageal echo. But the problem we run into there is it takes a lot of technical expertise, and it may not be something that can be used continuously, especially like in an ICU setting. It's more of procedure-based or during like acute resuscitation, something like that. So echocardiography is consistently evolving. Transthoracic echo may work. The problem you run into with transthoracic echo a lot of the time is the patient. You have somebody that's obese, somebody that maybe can't lay flat. A lot of those things can be very hard to evaluate their cardiac structures because you don't get a very good exam. Now that you guys have had some time with the ultrasound, you've seen how difficult that can be. Some views that may be helpful for you, and this is really kind of the focus views here. And you guys have looked at these when you were doing some of your echo training. When you guys come for Symposium, we'll have the new echo trainer up and in place so you guys can get some hands-on time with that as well, because it'll allow you to actually do TEs, TTEs, and see pathology, plus the kind of the learning program portion of that. What we're using now for the most part is intraoperative TE. We can use it as not only a monitoring device as far as valvular function and de-airing of the patient, but we can also use it as a rescue tool to determine whether we're dealing with valvular issues, volume status, lots of those things. The problem we run into, and there's very few of them, is that a lot of those patients tend to be a little bit older, and as a result of that, they may have had some esophageal procedures done. So you may find that you can't use the T because of esophageal varices, or sometimes laparoscopic banding of the esophagus. So that's really it. As far as things to think about for the test, know your numbers. So be familiar with all the cardiac output formulas, be familiar with the locations of the catheters as far as different landmarks inside the heart. So those are kind of the easily testable things. Otherwise, it'll be kind of scenario-based things. You get this picture. What do you think is going on with the patient? Question-wise, Megan said, what stroke volume variation tells you to try fluids? In the summer, we learned greater than 15%. I think, honestly, the book answer is greater than 11%, Megan. I usually say greater than 10 because it is kind of an approximation, but I think it really varies from one to another. When you guys come for symposium, Edwards is going to do a kind of hour-long lunch lecture on non-invasive cardiac monitoring because they've got some new devices out that are pretty beneficial. They may be able to give you a little bit more current view from their perspective as far as when they feel like you're fluid responsive. But 11%, I think, is what I've learned. I just use 10 because it's an even number. What other questions do you guys have? As far as content and preparation for the exam, this is the last lecture for exam 1. So on Thursday with Dr. Mordecai, that will be stuff for exam 2. AUC is area under the curve.
Dr. Cornelius, there's a like anesthetic implications for geriatric patients at lecture with Kane listed under week 3. Is that something that we're expected to know for this upcoming test? Sorry, I could look at the syllabus too. I'm sure it's on there.
It's going to be Dr. Mordecai doing that on Thursday, but that will not be on this test. That starts unit 2.
Great, thank you.
Yeah, no problem. All right, that's all I have